Hi everybody, and welcome to our module on headaches. There are a lot of disease processes that cause headache, and a lot of them are life-threatening and very dangerous to your patient. So in clinical practice, when you encounter someone with a headache, one of the first things you're going to do is spend a lot of time by history and physical exam trying to determine whether or not they have one of the dangerous causes of a secondary headache. So some of the things that can secondarily cause headache are tumors of the central nervous system, bleeds. Subarachnoid hemorrhage in particular causes what some patients describe as the worst headache of their life. Hydrocephalus, which we talk about in another module. Inflammation, especially temporal arteritis, which is inflammation of the temporal artery, is a dangerous cause of headache. So in clinical practice, you're going to spend a lot of time to rule these things out. And one of the key findings on physical exam is a lack of papilledema. If you can do a very careful fundoscopic exam and see that there's no papilledema, this can really help because a lot of these things cause increased intracranial pressure. There are three primary headache disorders that you should be aware of, and those are the tension headaches, the migraine headaches, and the cluster headaches, and we're going to talk about all three of these in this module. So the first one is tension headache, and this is very common. Most of you have probably had one of these in your life. The etiology is not clear, and it's probably multifactorial. It is a bilateral constant pain across the forehead and around the head. The pain is pressing. Some people describe it as a vice around their head, tightening around the head. It can last anywhere from 30 minutes to several hours. And very importantly, there's no photophobia, which is fear of bright lights, phonophobia, which is being bothered by sounds, or aura. We'll talk about what an aura is in a moment. You diagnose this headache clinically. There's no blood test or radiology for this, and you usually treat it with NSAIDs. And if any of you have ever had a headache after studying for too long and taking some ibuprofen over the counter, this is probably what you are treating, a tension headache. The next headache is a migraine headache, and in contrast to tension headaches, these headaches are almost always unilateral. Patients describe them as pulsating. They often have photophobia and phonophobia, so they don't like bright lights and they don't like loud noises. If you've ever had a migraine or you know someone who's had a migraine, they like to lie in a quiet, dark room because it makes them feel better. These headaches often have nausea and vomiting accompanying them, and they often are preceded by an aura. We'll talk about that in a minute. When you diagnose migraines clinically, there's no blood test or imaging for this. So an aura is the gradual development of a non-headache symptom, and most patients with migraines have a unique aura that they recognize when their migraine headaches are coming on. About a quarter of migraine patients have an aura. Classically, it precedes the headache, so they get the aura first and it gives them a warning that the headache is coming. In real life, the aura sometimes occurs at the same time. It is often visual, and this is a classic description you should know for board exams. Migraines can be preceded by a visual aura, which is alternating bright and dark spots. They'll call it a scintillating scotoma in the board question sometimes. Other patients have sensory auras, which include tingling in a limb or a face, and there are rare auras where people have problems with speech or motor dysfunction. Patients with auras get very familiar with these symptoms, and when they feel them come on, they know they're about to get a migraine headache. Some patients have triggers for their migraine. Some women have recognized that menstruation triggers a migraine headache. Other patients have reported stress or not eating enough, and there are many, many triggers patients have listed. Neurologists will often encourage patients to keep a diary and see if they can figure out what triggers their headache, because if these things can be avoided, it's a very simple solution to lessen the frequency of migraines. Migraine etiology is still incompletely understood. It used to be believed that vasodilation was the cause, and the reason this was believed was because vasoconstrictors seemed to help. It turns out that is probably incorrect, and the reason vasoconstrictors help was because they did other things besides vasoconstrict. There are a couple of pathologic processes that are thought to be important. The first is irritation of certain CNS structures, especially the trigeminal nerve. If you want to remember one thing about migraine etiology, it's that the trigeminal nerve is involved. It looks like when the trigeminal nerve gets activated, these vasoactive neuropeptides get released, things like substance P and neurokinin A and calcitonin gene-related peptides. Somehow they conspire to cause this syndrome. There's also a process called sensitization that seems to be important. The neurons are increasingly responsive to stimuli. How all this comes together to cause a migraine is not understood, but you should just know a few things about the pathophysiology for your board exams. When you talk about treating migraines, you have to talk about two things. The first is abortive therapy, which means drugs that make the migraine go away. And then the other is prophylactic therapy. So patients who have frequent migraines will take a drug so that they don't have them so often. So let's talk about abortive therapy first. And the mainstay of abortive therapy for migraine headaches is the triptans. These are drugs like sumatriptan. They are serotonin agonists, and serotonin is sometimes called 5-HT, which stands for 5-hydroxytryptamine. There's also evidence that they inhibit the trigeminal nerve, which may play a role in migraines. There's also evidence that they decrease vasoactive peptide release, which may help in migraines. These drugs are also vasoconstrictors, and remember, we used to think drugs for migraine worked by causing vasoconstriction, so it makes sense that many of the effective drugs are vasoconstrictors. They can raise your blood pressure, and make sure you remember this because the boards like to ask you about the effects of drugs like sumatriptan. Because they're vasoconstrictors, they're contraindicated in coronary disease and coronary vasospasm like Prinzmetal's angina because they can precipitate ischemia. Other options are ergotamine. Ergotamine's a vasoconstrictor. Before triptans, it was the major migraine drug, but it's not really given anymore because it has more side effects than the triptans. In particular, if you use it too often, you can get an overuse headache, and it can cause ischemia to digits and give gangrene. And then sometimes people use plain old NSAIDs to treat a migraine, but by and large, what you'll see used when patients come into emergency rooms with severe migraines are the sumatriptan type drugs. Patients who have frequent migraines have the option of going on preventative therapy, and there are 3 drugs that are used. Topiramate and valproate are anticonvulsants, and propranolol is a beta blocker, and let's talk about each one of those. So topiramate is very effective for migraine prevention. The exact mechanism of this drug is not understood. You'll probably not be asked about the mechanism of topiramate on test because we really don't know why it works for migraines. Most anticonvulsants work by either blocking sodium channels in nerves or increasing the function of GABA, and topiramate's been shown to have both of these effects. But how this helps with migraines, we don't understand. A major side effect of this drug is that people can feel a little bit foggy. They get mental dulling and sedation. And this can sometimes be a serious problem if you've got a young, hardworking person who needs to take this drug for prevention of migraines. They may be reluctant to take it and just want to roll the dice and see if their headaches stay away. It can also cause paresthesias, and it can cause weight loss. And then topiramate is a weak carbonic anhydrase inhibitor, so this will lead to more calcium in the urine, and you can get kidney stones on this drug. Patients who take topiramate are often told to hydrate very well while they're on the drug. Valproic acid or valproate is also an option. It is an anticonvulsant, just like topiramate. It has many more side effects, so it's used less commonly than topiramate. It can upset the stomach. It causes tremor. You have to follow the LFTs in patients on valproic acid. It's associated with neural tube defects, especially spina bifida. So in women of childbearing age, you have to watch this drug. Topiramate also shouldn't be used in women of childbearing age because of potential teratogenicity. And it can cause weight gain in contrast to topiramate, which can cause weight loss. Propranolol can also be used for prevention of migraines. It's a non-selective beta blocker, and it carries all the usual side effects and precautions that go along with using beta blockers. So it can exacerbate bronchoconstriction and COPD. You have to be careful in diabetics because if they get hypoglycemic, in theory, the beta blocker can mask the symptoms of hypoglycemia so that they don't feel it. And then it can also cause side effects like fatigue and erectile dysfunction. So let's talk about what to do in someone who is pregnant and has migraines. Well, the good news is usually women have less headaches while they're pregnant, so that alone helps. Triptans are okay to use for abortive therapy, but generally you need to avoid anticonvulsants, ergotamines, and NSAIDs. And what this means is usually women stop their preventative therapy if possible. All right, the last headache we'll discuss is the cluster headache. This is a very rare headache that you're unlikely to see clinically. It has a poorly understood mechanism. It mostly happens in men. That's the classic presentation. It's more common in smokers as well. And it causes excruciating unilateral headache behind the eye. And remember, the word excruciating comes from the same root as crucifixion, so that's how bad the pain is. This is very, very severe. There are a lot of associated autonomic symptoms, so patients will have tearing and rhinorrhea, so their nose will be running. They also get autonomic dysfunction, so they can have a Horner syndrome on one side, with ptosis and meiosis of the eye. Unlike migraine, there's no aura and there's no nausea and vomiting associated with cluster headaches. These come in clusters, that's where they get their name, so patients will have attacks every day for a few weeks. And the headaches tend to have a circadian rhythm, so they'll get an attack every day at the same time of day. And when you see this in a board question, it should tip you off right away that it's a cluster headache. The symptoms last 15 minutes to several hours. One thing you might confuse it with is trigeminal neuralgia, which is also very painful and also can occur on one side of the face. But the pain from trigeminal neuralgia is quick and goes away in a minute or so. These will last longer. It has a very interesting option for treatment, and that's oxygen. Patients who are given oxygen seem to get better through an unclear mechanism. It may be related to the oxygen causing vasoconstriction because you deliver so much oxygen to the brain, but we don't know if that's correct. Oxygen may inhibit neuronal activity in the trigeminal nucleus, so that may help, but we really don't know why. Triptans also seem to have some benefit in headache and are sometimes used. And that concludes our module on headache.